Hi, everyone. Thank you for joining us for today's webinar presented by Aspire Respiratory Products. Our speaker today is Ali Holmes, and this webinar is entitled Spot the Gains, Harnessing RMST to Leverage Transdisciplinary Goals. Ali Holmes is a certified brain injury specialist and board certified specialist in swallowing disorders. She is the SLP advisor for Sheltering Arms Institute and has led the development of specialty programs in swallowing, voice, stroke, pulmonary rehab, tracheostomy management, and Parkinson's disease. She also regularly presents on the state and national level. And Ali, we are so glad to welcome you here today. We are so excited to learn from you. I know respiratory muscle training is definitely one of my favorite interdisciplinary tools, but I still have people who are surprised that other disciplines can participate. So with that, I will hand over the floor. I will just ask everyone to please hold their questions until after the presentation for the Q&A. Thanks, Ali.
All right, thank you. Thank you, Jenny and Aspire, for having me, and thanks to all of you for tuning in at the end of the day. I appreciate it. So Spot the Gains. S.P.O.T is an acronym I put together just to honor my speech, physical, occupational, and therapeutic rec counterparts, because we have been learning more and more that that's just a few of the disciplines who can see gains in their patients' goals through the value of respiratory muscle strength training. So we're going to talk about that today. I've got some learning objectives up here. Obviously, this is a huge topic to cover in less than an hour, so I'm going to go through some fundamentals. I encourage you to explore this topic further, and please, reach out to me. I love to have more conversations about this. I feel really passionate about respiratory muscle strength training and what it can do of value for our patients. So we'll talk a little about the benefits of RMST and cough skill training and rehabilitation, and talk about those transdisciplinary team awareness of RMST for knowledge translation, how we evaluate and create treatment plans to remediate cough and respiratory muscle strength, and how to identify appropriate technology and protocols, as well as outcome measurement. So let's talk first a little bit about knowledge translation, which is the exchange and synthesis and application of knowledge within a complex system of interactions among researchers and users. So I've got the knowledge to action cycle on your screen there, which shows the process that we take when we have information that we want to put into practice for the benefit of our patients. Working this cycle can help if you've ever had an initiative that you take on and then 3 to 6 months later, you wonder, what happened to that? We talked about doing that and we started and it kind of fell apart. Working this cycle can really help, because it can really help to shorten that gap. There's this widely quoted statistic that there's this 17-year gap from something being discovered in the research world to it being applied with our patients. And we want to shorten that. We really want to put the latest in care into practice for our patients for their benefit. And our role as clinicians is really to implement those best practices and deliver those optimal outcomes for our specific patient populations. So we really want to work to close that gap between evidence and decision-making to improve those outcomes. So working this cycle means, we take that information that we've got, we put it out there for our team to learn, but then we want to constantly be evaluating the outcomes. Are we getting what we want out of it? Are we able to sustain the use of this with our patient populations? If there's any problems that we're noticing or any barriers, can we adapt what we're doing to meet that, and constantly be assessing and tailoring and implementing different strategies, interventions, so that we're achieving these end goals? That's working the cycle, basically. So from that, an example of that KT principle in action was our adoption here at Sheltering Arms Institute of not only respiratory muscle strength training as a protocol, but also cough evaluation and management. I had some information I acquired from a presentation back in 2022 about the benefits and latest research on addressing dystusia, or disordered or weakened cough, and how important that is in our evaluation and treatment of the swallow. So this is an example of a slide that I shared with the team when we were initially talking about how important it is to look at cough. And we wanted to make sure that we were standardizing our approach to rehabilitating that at the hospital. So now we know that assessment and treatment of both swallowing and cough should be a part of a standard clinical practice. And on that continuum of airway protection, from the preventative of swallowing, a bolus, to reactive or coughing if a bolus is going down the wrong way, now we have tools to measure and quantify that. So looking at that framework, again, just to put it into like a visual perspective on that continuum from something preventive in our airway mechanisms of the swallow to reactive with the cough. We know that impaired cough, or like I said, dystusia, is characterized by maybe a blunted reflex cough sensation or a weak or ineffective cough from a motor response perspective. So assessing cough can improve the accuracy of identifying and predicting someone with dysphagia. So it's a really useful addition to your battery of screening tasks. And then, assessing cough, again, if you can see here in the image, is going to give us some more holistic understanding of airway protection. We want to understand how well a patient with dysphagia can clear aspirated material from the airway, in addition to understanding how frequently or how severely they aspirate. Patients who aspirate but can clear their lower airway of foods and liquids through effective coughing are going to be managed clinically much differently than people who aspirate and cannot clear their airway because of an ineffective cough. So we can look at also this full continuum in a broader spectrum here, and this is taken from Michelle Trochet's work. So again, in her words, airway protection is very functionally complex, and it's a continuum of behaviors with cough and swallowing at either end. And that effective swallowing, we know, is going to prevent the material from entering the airway. Effective coughing is going to eject it. And they both consist of highly coordinated sequences of structural movements. They both require, reconfiguration of the ventilatory breathing patterns. And there's a lot of overlap in these two behaviors in sensory and motor control execution. So we are serving our patients best by addressing both. So when we look at a cough, we know it's comprised of three phases: inspiratory, compressive, and expiratory. And that's obviously a vital defensive mechanism for our lung health. It helps to prevent aspiration, promote ciliary activity, and clears airway debris. So we know that inspiratory phase, like you see right there on the left, that's when we're inhaling to bring up the volume that we need for an effective cough. In that compressive phase, the larynx closes, the muscles in the chest wall, diaphragm, and the abdominal wall contract, causing that rapid increase in intrathoracic pressure. And then in the expiratory phase, the glottis opens, causing that high expiratory airflow and the coughing sound. And that's hopefully going to serve to dislodge anything from the airways and allow it to be removed. So when we're going to treat dystusia, we can take it from a skill-based approach, a strength-based approach, or often both. So we might use something like an RMST to work on the strength, and we can also work on the skill of your cough, and we're going to talk about both. When we think about what makes an effective cough and how we're going to describe the type of cough we look at, I have learned quite a bit from Dr. James Curtis and his work with the Air Lab at Cornell. And when we look at cough, we look at, the strength of how we're perceiving the strength of someone's cough, how crisp it is. People can have those coughs that just lightly rattle and don't really go anywhere. What's the perceived amount of voicing? What type of expiratory effort are you seeing from your patients? Is it a true cough, more of a throat clear, kind of a vocalization / grunt? So when you look at that, you can look and try to determine whether you want to look at a strength-based approach to cough rehab. And that might be the more ideal approach if the primary cause of the weak cough is peripheral muscle weakness. But if the cause of the dystusia is due to changes in motor control and coordination, a skill-based approach to cough might be a more effective approach to rehab. So we're going to talk a little bit about how we address both. Let's start with respiratory muscle strength training as an umbrella term that can refer to RMST or IMST training, depending upon patient-specific needs. But the goal of the training is to strengthen and increase the muscles of respiration by increasing their force-generating capacity. We know that skeletal muscles have fast and slow twitch fibers, with fast twitch fibers generating force but are prone to fatigue, like in coughing, where slow twitch fibers are slow to contract but resistant to fatigue, such as the ones we might use to help hold our neck up. Respiratory muscle strength training in general will stimulate those fast twitch fibers, which can result in muscular enlargement. And that's what we're looking for, is that hypertrophic change. When we're using a device like the EMST, this is straight from the website, we know that it can address the 4Ds. And I always love this for teaching students. We know that we are going to be able to use this for difficulty swallowing, for a disordered cough, for a weak voice, and also for shortness of breath. So it's pretty incredible that we can address all of those things with a simple tool. It's had been shown in several studies to help improve that muscle force generation of the swallow muscles. We also know that we can help improve muscle forces for generating that max expiratory pressure, and that helps in a better ability to produce a higher flow, which we're going to want and is very critical for coughing. So the EMST, or respiratory training with a pressure threshold device, is key for a lot of these goals. But before we get into the how, I want to talk a little bit about the why and do a brief review of neuroplasticity. We know that that's the ability of the nervous system to change in response to intrinsic or extrinsic stimuli by reorganizing its structure, functions, or connections after injury. And it's crucial that we address everything with an underpinning and understanding of neuroplasticity, because we really have the power to change our patients' brains, which is pretty fantastic. And our patients' outcomes can be dependent on the type of therapy they receive. So I always tell my patients when they tell me they're working, really hard, good, we want that, because we know that your outcomes are going to be better based on the type of therapy we're giving you. And if we're just doing stuff that's too easy or not challenging or stressing you in any way, we're not going to get anywhere. So when we think about the 10 principles of neuroplasticity from the very popular Kleiman-Jones article, I'm going to just spend time highlighting 4 of these: use it and improve it, repetition, intensity, and salience, as they apply with our work in EMST. So use it and improve it. We know that training that drives a specific brain function can lead to enhancement of that function. Improvements in sensory and motor performance brought about by the skilled training are accompanied by plasticity within the cerebral cortex. So we know that evidence-based interactions should be used to retrain those lost or decreased skills, and that's going to help us improve our performance. Practice does make perfect. So think about how this relates to what we're doing when we set our goals for RMST and or cough skill training. Then looking at that repetition principle, the act of repeating, and how induction of plasticity requires sufficient repetition. And that newly learned behavior, we go over it and do it again and again and again to really induce those lasting neuro changes. So we want to make sure that they are acquiring skills and continuing performance of that skill over time. So we have to learn the skill first, but then we repeat it and repeat it and repeat it to drive that plasticity. Let's talk about intensity. It's really important to grade your intervention. Always, always check in with your patient. And we use the rating of perceived exertion, or the Borg RPE scale, with our patients, where they rate how hard they're working on that scale of 6 to 20. The reason we use that in our facility is because our physical and occupational therapists use the same 6 to 20 scale. And it's, I think, helpful for our patients to be, speaking the same language to all of their clinicians. So again, when you think about that intensity, it's this measure of how hard that activity feels to the person when they're doing it. We know that high intensity stimulation, that's what's going to really help bring about that long-term potentiation. So we have to grade the interventions effectively so that it's intense and that it stays intense. So somebody doing something at a certain setting week 1, if they're still at that setting week 4, we're not really going to be impacting long-term change. So on that 6 to 20 scale, I'm typically looking for my patients to be exercising in that 13 to 15 range, that hard range, that green area on the diagram. I'll usually say a 6 is like taking a nap, and a 20 is like running a marathon. How hard are we working? And I check in on that a lot. Definitely when we're first setting out to do this, but then honestly every session, because they're going to be getting better and they're going to start making some pretty quick changes. And I want to make sure that I'm titrating this so it still feels effortful. And then let's talk about salience. We want it to be important and meaningful to the client to induce that plasticity. It's got to be salient. It's going to really help with that strength of that memory consolidation. And it's also going to be more motivating, and it's going to be, promoting that good engagement when they can understand, yeah, I cough and I need to cough. And that helps me, and when they work with their device, I know that, working with an EMST may not feel like directly salient, but in our conversation and teaching, we know that it's meaningful and engaging when we can explain it in the way that they understand immediately that effect to their end goals. So let's talk about device selection. We always want to make sure that our patients are using pressure threshold trainers. And this was a bit of a battle years ago when I was first introducing and bringing the concept of trying to incorporate RMST to a facility I'd worked in prior. They would say, hey, respiratory therapists have already given out a lot of stuff to our patient. They have this inspiratory spirometer, the device that we call the pickle that you see there at the top of the screen. Why do they need something else? And it was good that I felt aimed with the tools to discuss the difference. And there is an important difference. Those are not training tools. And the inspiratory spirometer is valuable, absolutely. And so is the acapella. But they have different purposes than what we're going for from an exercise perspective with a pressure threshold device. And when you're using a pressure threshold trainer, they require the person to generate enough pressure to open that one-way spring-loaded valve that's within the device. And the amount of pressure required to open that, we can adjust with the knob at the top. And that if the person doesn't generate enough pressure to open the valve, the device won't make a sound. And if they generate enough pressure to open the valve, they get that immediate feedback with that release, that hissing sound. And it's not like airflow dependent, where if you have a resistive trainer, depending on how they alter their airflow, they can still get that auditory feedback that they've done something, but it's much tougher to calibrate, and it's not necessarily equivalent, like that the sound you get is equivalent to you doing the exercise with the intensity that you think you're doing it with. So that's why I prefer a pressure threshold trainer, and research has shown that that is what you want to use in order to be able to address those principles that we were just talking about. Resistive trainer is, like I said, more flow dependent. So that amount of resistance depends on the rate of airflow. So standardization and consistency across trials can be difficult. But with these pressure threshold trainers, you've got that relief valve. You can allow for greater loading for those target muscles, and it's more favorable for actually training and making a difference in those muscles. Now, we can also do inspiratory muscle strength training by simply using the IA150, which is the inspiratory adapter. So you can pop your device into the end, and then they are sucking in to work the inspiratory muscles. And then you can separate the two, and they can use the EMST on its own if you are doing expiratory muscle strength training. So it's really handy that we are able to distribute both and have our patients use both depending on what their goals are. And this next slide simply shows, and again, this is off Aspire's website, how you can actually find your initial settings with your EMST and then incorporating it into the inspiratory adapter, the IA150, to be able to draw air in and figure out your starting levels. For our patients, it really is very dependent on their diagnosis, how I'm going to start with them. Someone with more of a degenerative neurologic changes, for example, I'm going to have a lighter load requirement. Somebody who had a recent CVA, maybe a brain injury, spinal cord injury, I might start them more at like 80% of their max expiratory pressure or max inspiratory pressure. But I just want to counsel them that I want them to be able to feel that hard effort, but over 25 attempts. So it's not going to be what that max was, because obviously you can't lift your heaviest, weight at the gym 25 times. We want to take it back, but I do use that weightlifting analogy quite a bit. And like I said, you really want to check in frequently to make sure that they still feel that same load and that that device is growing with their gains. So again, when you're making some decisions between what you're working on, there's lots of charts available online that can help guide this, and even helpful information on the website. But when you are working those inspiratory muscles, that's addressing your diaphragm, your external intercostals, where that expiratory muscle strength training is we focus more on those abs and your internal intercostals. And like I said before, those respiratory muscles are skeletal and can be affected by exercise, but adding that isometric load is what's going to help make the difference. And let's get to the spot the gains part. What's really, really exciting is that we, remember those 4Ds. We use this tool with a lot of our patients who have swallowing issues, a weak cough, voice problems, they have shortness of breath, COPD, and we're seeing those gains translate into the other therapies. which is really cool. And a lot of studies are backing this up. I've got a bunch of references I'm happy to share that are on the slides later on, but there's been systematic reviews that have found that, for example, inspiratory muscle strength training can increase diaphragmatic strength, decrease the work of breathing in our patients, offer enhanced aerobic capacity and exercise tolerance. And so that was a study that was done in a journal that they were trying to show how it is affecting balance and functional mobility. How cool is that, right? Because in inpatient rehab, we have 2 weeks in our setting on average to get people to the point where they can discharge safely. And if what I'm doing in speech is going to help affect those mobility goals, all the better. Also, multiple studies have found that respiratory muscle strength training can decrease shortness of breath in patients with COPD. They found increased distance in the 6-meter walk test in patients with COPD, increased respiratory reserve and decreased work of breathing in patients with MS, and then improved cardiorespiratory performance in individuals following open heart surgery. Also, reduced complications and length of stay. How exciting. And that's courtesy of an article that was published just this year in the Advances in Respiratory Medicine journal. And then in spinal cord injury in particular, multiple studies have found decreased occurrence of respiratory illness, increased muscular strength, increased cough effectiveness. And we know it's essential in this population. The number one cause of death in the first year after spinal cord injury can be pneumonia due to that ineffective cough response, especially if their injury is in that like C4 to T12 levels. They're really at increased risk developing respiratory complications because of that impaired respiratory muscle strength. So we began adding assessment of cough to our required outcome measures to then target with goals for all the patients on our SCI unit that we see. And we found that we were best serving our patients by not limiting our assessment to those with dysphagia. A lot of our patients working on cough are on regular diets, but we know that they could be one upper respiratory infection away from really being in trouble. So we like to build that reserve and teach those skills prophylactically, and we are seeing nice gains in the time they have with us. There are certainly precautions and contraindications. RMST is not for everybody every time, so I'm throwing a slide up here, but obviously we will check in with our doctors if we have any concerns or if there's any, possible precautions that we need to take. And for a more comprehensive list of these, please visit the Aspire website and of course talk to your physician, but I did want to share that. So let's talk a little about capturing some of these baseline measurements or outcome measurements. We like to capture peak expiratory flow rate, maximum expiratory pressure, and inspiratory pressure. And these objective measurements for assessing cough involve using instruments that are capable of measuring cough airflow. So that handheld peak flow meter that you see on the right, that's one such instrument. They're very inexpensive, they're portable, they're relatively feasible to use in clinical practice. And what that peak flow meter does, and there's different kinds. I had an image of a different one a few slides ago. They're often used by people who have asthma. They measure the speed of the air that's exhaled during breathing or cough. And that peak velocity is measured in liters of air per minute. And when that peak velocity is measured for cough, it can be referred to as cough flow rate or cough peak expiratory flow rate. And we tend to measure both. So if we're going to help our patient in capturing their peak expiratory flow rate, I'll have them inhale as much as possible. And then if I want to capture the cough, I'll have them cough hard once with the device. And I will capture that also with a max exhale. I'll usually try to get a few trials just to see that what I'm getting is consistent. But you also want to really think about our patients who have a spinal cord injury. Know that positioning is crucial and variations can provide quite different results. So I always want to see, I try to be consistent in how I'm treating them. So if they're always comfortable upright in bed or upright in their wheelchair or in a tilt and space wheelchair, I want to, keep that perspective in mind that different positions can definitely have different results. So if we are going to capture those initial measurements for max expiratory and inspiratory pressure, you can use a manometer. And there are very fancy ones and also a lot of really helpful, hacks you could say out there for using less expensive devices in your facility. There's a lot of information available online. You can purchase a commercial one for far less than ones that are used in research labs and then add some special tubing and one-way valves. Dr. James Curtis has a detailed explanation on his site that you can refer to. I've got it listed there on the slide. And Brooke Richardson is another SLP with specialized training in all things RMST, and she has a lot of educational resources and information on manometry available on her website as well. In our practice, currently, we use the device itself to calibrate and estimate max expiratory and inspiratory pressure. And what we will do is use the device itself and the chart that I'm going to show you guys to calculate those numbers. But what is so important is measurement. Measurement is crucial. And that's what I mean by collecting those initial measurements, those initial outcome measurements. And we'll talk a little more about that, about outcome. I have a section on outcomes coming up. But again, considering those principles of exercise science, we're really going to hit repetition and we're really going to hit intensity with this. When we calibrate the EMST light, we have a tiny little screw that you can see circled up there. And that screw is right there at that 5 centimeter or that lightest position. And that's when the device is at its lowest pressure. The device has 4 pillars, and you can see those red arrows pointing to them that are all placed equal distance apart. Each pillar serves as a visual marker for a quarter turn. And I gave a little tip. We'll take a Sharpie and use that pen to note the numbers 1 to 4 on each pillar, and that can help track quarter turns for your patient. Especially helpful if you're in an outpatient type setting or a telehealth, that the device can be marked for the patient. You can be cueing them, let's try it cranked to 2, try it cranked to the 3rd position. And that helps quantify how hard they're working. And this is really helpful to us that we know between that 5 and 35 mark on the device that each quarter turn is 2.5 centimeters. So we're starting with 5 and just doing that simple math. And when you get to that 35 to 75, like the second half down on the crank, 1 full turn is actually 20 centimeters. So a quarter turn is 5. So I will adjust, have the patient blow, adjust again. And you get pretty good at realizing, like, if I could go more than a quarter turn, that was very easy for them. But pretty quickly, you can figure out where do you get to that point where they can't blow anymore. Go back a quarter turn, and we'll use that as our max, as our MEP. And then that's where I'll make my calculation if I want to start them at 80% of that number, let's say, for the actual exercise, which is typically 5 sets of 5 breaths once a day. And this is just a clip from a patient education piece where we talk about using the EMST and how we instruct them to do it. I have a device I carry around with me. I think a lot of my team members do, so we can help with our patients who have some cognitive impairment. It can be really helpful just to be able to just do what I do, and just show them. Often we have to hold the device for our patients, especially those with a spinal cord injury. It does come with those nose clips if you need them, if there's a lot of velopharyngeal insufficiency. Sometimes with my patients who've had a stroke and there's some oral weakness, I need to actually have a gloved hand to help with that seal. So the caregiver can certainly help with holding the cheeks, like it says here, so they don't lose air out the sides on those attempts. But we train them to understand that as long as they get that feedback and they hear that sound, they know they've done it right, and that they want to make sure that it feels hard and they get that feedback. If they can answer yes to both of those, I tell them they're doing it right. We do encourage that rest between breaths. And I usually have my patients rest about a minute between sets. And I tell them they should feel like they need that minute. If they feel like they can just rush through and do all 25, we probably don't have it calibrated correctly. So that's a good sign to go back and check that it feels hard enough that they want to take a break. So that's yet another of those like checkpoints to make sure that you have your device calibrated correctly. So as far as training takeaways, think about those exercise physiology principles, focus on intensity, repetition, salience, and make sure you're adjusting that dosage based on patient performance. I also wanted to give you, and this is freely available online, like an example again of that RPE scale. We actually have these laminated in all the speech therapist offices, or they can pull it up on their laptop to show the patient when they're learning, but they pretty quickly get a handle on, giving their number, or even if they can just tell me they're working hard. That's fine too. But again, we just want to assess often. And we also want the patient not just to tell me hard, but if we're working on their cough and I'm cueing them on those cough skills, when I do that, I will often go through a series where I want them to cough hard. And we talk about how that should feel and how that should be perceived by them. Does it sound crisp? Does it sound clear? Did it feel effortful? And we practice coughing in different like varieties of speed and several coughs in a row versus several hard coughs where I take a good break between each one, trying to modulate a gentler cough to see if they can control that. And then maybe like at the end of the session, we'll actually cough into the peak flow meter itself just to get a measurement and see how their cough is tracking. So that's how I might balance working on some of the skill of coughing as well as working on that strength. So let's go back and chat a little more about outcome measurement. When we talk about outcome measurement and defining those measures, that's when we're simply generating scores to quantify their performance based on some standard protocols or some questions, depending on the type of outcome you're using. And we want to measure change, so we're going to collect data at 2 or more points in their functioning, in their performance, or their participation over time. And that's what's really unique in outcome measures, is that tracking change and how important it is to capture what they do at the beginning and what they're doing at the end, and in between with serial measurement too. When we capture outcomes, we have it built into our electronic medical record. So we actually have an outcome tab where we have this part built in. And these are what we call performance-based measures. We're measuring how the patient performs on giving us their max expiratory pressure, max inspiratory pressure, their peak flow for their cough. And we want to capture this at evaluation, again at discharge, but also at these midpoints. And that's really important too for looking at that change. And we'll talk about all the benefits of serial measurement. So in our notes, we can actually get into that outcome tab every session if we want to. You also look at, besides performance measures, patient-reported outcome measures, also referred to as PROMs. And here's just a little snip of some of the ones that we have embedded in our software. And that's a really fundamental component of swallow management and outcome evaluation, because that's going to really help inform treatment consequences that we can't capture just by these objective numbers. How is their disorder affecting them? We know what's driving their mechanical function, but how is that impacting their daily life? And again, the few I've shown here is certainly not exhaustive, depending on your rationale for what type of therapy and why you're using respiratory muscle strength training. You may have measures for perception of dyspnea, for example. But the important part is, I think, having a nice combination of both performance-based and patient-reported measures to report on. And we know that measuring those outcomes has a lot of evidence-based benefits. Again, it's really going to help direct our plan of care and do it efficiently. It helps, sort of streamline that communication between our patients, physicians, and of course, even our payers, right? Because it helps justify therapy. It's also really motivating, I think, for our patients. Besides performing these outcomes, it's really baked into our culture that we discuss what it means with our patients when we're doing these measurements, and that we're coaching and counseling them on why it's important and getting their feedback on what they're taking from it and how it matches with their goals that they want to work on. It keeps the clinician accountable. Are we doing effective therapy? And our current strategies, meeting what they need? And it can also help a lot with like discharge destination and planning, and predicting risk of adverse events. It's really, really important. And I'm so grateful to work in an environment of measurement. And I hope that you guys are using some of this where you're working as well. We know that it really is the best evidence-based practice to use measurement. It's important for goal setting and maintaining patient-centered care. And the patient being able to connect outcomes with their own goals is very evidence-based as well. And then, of course, using those outcomes to guide what we're going to choose for our intervention. And it really leads into this concept of shared decision-making with our outcomes. We know that, it leads to these really lovely conversations with our patients on why we're measuring what we're measuring, the purpose of why we did it, how to interpret it. And it helps, it helps for us to be able to put this into wording they can understand and how it relates to their goal. So we have a goal to increase their max expiratory pressure to some norm. They have a goal that they don't want to choke when they're eating, or they want to be able to eat and feel comfortable being in public in a restaurant. That's how we should be wording these goals, really taking it from their perspective. And it also just helps us show too, measuring their improvement and being able to show them when they're maybe not seeing a big picture, or they've been seeing such gradual change over time. And we can go back and say, hey, when we first gave you this, patient-reported index of how, your swallow is affecting your daily life. This is the rating you gave it, and we did it again today, and this is what you said. And these are the areas where you saw improvement. That can be a real aha moment, along with me showing numbers that make me happy. Being able to relate it to their quality of life, it just can really continue as a good check-in to help manage expectations and to help show the purpose of what we're doing and really work on that teamwork type approach that we want to foster in the relationship with our patients. That we're not just on the sidelines as a coach or a cheerleader, but like we're there as part of the team with them. And when we take that serial measurement and take that measurement as, at intervals within our therapy, that's really just so important because we're going to be able to track progress and quantify improvement and help inform our decision-making as clinicians. That data can help us know if we need to adjust or modify a treatment plan. If they're not progressing as expected, this data can help prompt us to change our techniques or explore another strategy. And also, conversely, this clear upward trend can indicate that, hey, what we're doing is effective. Let's keep chugging along. It can be really motivating for patients and caregivers. It can be very powerful to build confidence in them being able to see the changes they're making and encourage their active participation. Providing evidence for advocacy and reimbursement, because that regular data collection provides valuable evidence to help justify the need for our services and help demonstrate the value of a specific intervention. It's really important for insurance companies and value-based care models, which are going to be helping providers with, who achieve positive patient outcomes. Also, I think this is key. It really offers that patient-centered insight, especially when you take into account those patient-reported outcomes, like I mentioned, to help ensure that your therapy goals are meaningful from the patient's real-life needs. While we've got these clinical measures that track a skill, those PROMs can really show that what we're doing as therapy is improving their ability to participate in activities that are important to them. And of course, we're going to be supporting evidence-based practice. Serial measurement is a real cornerstone to EBP because it's helping provide us with the data we need to evaluate the effectiveness of our interventions over time. So in our facility, we have software we can use for dashboarding as a clinical tool. So, this is just a snip of one of our serial measurement dashboards for peak expiratory flow rate. So I can pull this up and we can slice our data many ways, but that line, those multicolor lines at the top are showing all the people that we were taking more than one measurement of while they were here as an inpatient with us. So some patients were getting up to like 7 repeat measures because they were here for quite an extended stay or because the clinician chose to measure it at increased intervals and showing averages of change, over time. And we were able to show that on average in a length of stay with us that patients are improving their peak expiratory flow rate by up to 60 liters per minute, which can be very crucial. One real important number with peak expiratory flow rate that's often quoted is 270. And if a patient can blow, cough at that 270 liters per minute, that's a benchmark for the amount of force typically needed to generate enough power to clear an airway. So we'll have patients who come in where their initial force might be 60, might be 80 or 100 if they've had a spinal cord injury, and we want to edge them closer and closer to that 270 while they're with us. And that is really important for them to understand and can be really helpful and motivating as well. So we can objectively really see if our patient's improving and help quantify their advancement by keeping track of these numbers. Another thing that those numbers enable us to do is be able to share what we're doing here with other stakeholders at the Institute. So we have created several impact reports, as we call them, where we discuss different interventions and the outcome of it and what we're doing on a broad level. So here's just a snip from an impact report I was able to create discussing our use of cough skills and cough strength training with patients specific to our SCI unit. And this was data that we collected last year. I have that number 270 on there. Is that minimal goal that we're looking for? We had an average peak cough on admission for our patients on our SCI unit of 223 and an average peak cough on discharge of 392. So that was really exciting to see. We were looking at some gains in that snip of time in peak cough of 110%, a 70% gain in their max expiratory pressure, and a 76% gain in their peak expiratory flow. So it's really lovely when you can actually take those numbers and not only use it just patient to caregiver to clinician in those little triads, but also big picture, being able to show, why what we do is so important. In wrapping here, I wanted to share some recent success stories. I want to talk first about a 69-year-old male that we had who had cervical cord compression and had a C4 to 7 laminectomy infusion. He had significant weakness and functional decline. He also had a past medical history of obstructive sleep apnea. He was seen for cough skill training in EMST, and we only got to work with him for 10 sessions, but we saw his cough and his peak exhale improve significantly just in those 10 sessions, working on that skill of coughing, but adding in that EMST delivered with intensity and repetition. And he felt so much perceptively stronger in his ability to cough and clear his airway, especially with his overall weakness. And it was really exciting to see. We also had another gentleman that I worked with last year who had severe Parkinson's disease and had a deep brain stimulator implanted. And this is a clip from my colleague who treated him from her discharge note, that he was able to demonstrate a peak flow of 520 liters per minute and cough of 350. Remember, our benchmark for that is at least a 270. We definitely want to be higher, but if we can just get to that 270 with some folks, I'm thrilled. But he surpassed that for sure. His measures were within functional limits for an adult male, not just an adult male with Parkinson's, but an adult male, which was really exciting. And he was really happy with these gains. He saw it as motivating, and knowing that his disease is degenerative, it motivated him to continue for gains and maintenance, to continue to keep his swallow as safe as possible and his cough efficacy as strong as possible with disease progression. So he was thrilled and so motivated. So it was really exciting to see how that can make a big difference in that quality of life. Also, we had a patient recently who'd had a heart transplant. So what I'm trying to do is show you guys like a lot of different populations where we're using this tool. And this I loved because the OTs and PTs were sharing things like increased activity tolerance, increased independence with transfers and balance. And the speech therapist, this is actually a current patient, he had actually improved up to 30 centimeters on the EMST, where he had started as closer to like 5 or 10 centimeters of pressure was the most he could deliver. So we're seeing some wonderful gains as we have him here with us working on his strength. And that's a picture of the device he was using for transfers when he first got here, the Sarah Steady, and now he's able to be more independent and stand and balance for a stand pivot and not be as dependent on a device. Now here's where we get into some good stuff. So this gentleman I adore. He had had a liver transplant, been a very complicated process. He was with us after a couple months of hospitalization. The patient and the physical therapist were noticing increased endurance and exercise tolerance after he started working with us. And he had a personal goal to resume playing the harmonica. He had been unable to generate enough force to do this since his transplant, and it brought him a ton of joy. So in our plan of working with him, we were incorporating inspiratory muscle strength training, expiratory muscle strength training, and I've got a little snip here from the concert that he gave to other patients prior. Couldn't you just listen to that all day? I love it. And along that line, we do not shy away from concerts here at the Institute. We have a music therapist on staff who's also a huge fan of what we do and works so beautifully with speech and with all the disciplines. Just a huge part of I need to incorporate an M into my spot, the difference, because she's incredible. And there she is on the left with her guitar. We also had a patient with us just earlier in the summer, 72-year-old musician, and he had central cord syndrome from a motor vehicle crash. And his timed up and go, that's the TUG score, had improved significantly enough to demonstrate that he was now above average with that score. He had been way below before, which demonstrated a decreased risk of falls. He also just wanted to be able to sit up. He wanted to be able to play music. He wanted to be able to use his hands. He wanted to be able to take his steps, and he wanted to be able to sing. And that is just so beautiful, the way that music therapy, speech therapy, occupational, and physical all came together for this gentleman. Now, this man put on a show. We had a lot of people turn out for this because he's a well-known local musician, and that is actually one of our lead physicians from the stroke unit on the right with his guitar. We have our physical therapy clinician from the spinal cord unit on her violin, and then our music therapist, and they all came together. The patient had a logo and a band name worked up for them. They're all in their matching t-shirts. So that was pretty exciting. Here. Isn't that great? So on that note, guys, I want to thank Aspire and everyone for your time today, and I will open up to questions. I also have references I'm happy to send out to you guys. And with that, I will turn it back over to Jenny.
Thank you, Ali, so much. I think this was so helpful to a lot of us who are trying to implement RMST and really focus on interdisciplinary practice. So thank you. We'll go into a few questions. Let's see. So, and I'll tell you what we answer here when people ask us, but maybe you have a different protocol or something you can share with your facility. But how long do you wait to do RMST post cardiac surgery? So we generally say we recommend medical clearance, and it really varies on a case by case, patient by patient basis, and to be conservative when you start and monitor very closely. Do you have a specific protocol or something else that maybe you can recommend?
Yeah, that's a really good question. So I don't know that I clarified this. I work in the inpatient rehabilitation setting. So a lot of times by the time the patients come to us, they have been cleared for that. And I would always, in that case, when they've had that open chest, recommend physician approval.
Yeah.
And we might start a little lighter than that 80% with them as well. And like you said, just case by case.
Yeah, perfect. Okay, somebody did ask about a paralyzed vocal cord, and I'll say that there are limited studies. There's actually one study for IMST in vocal fold paralysis, and if you want to email me, Jenny at EMST150, I'm happy to share that study with them. But generally, RMST maybe won't fix the paralyzed vocal cord itself, but it can strengthen the supporting system. So helping with a stronger cough, subglottic pressure, and things like this.
Exactly.
Kind
Yeah.
of yeah.
And I will use it with that population. I agree.
Yeah. Okay. And Parkinson's disease, do you see the training efficacy transfer to voice strength?
We can, yeah, because I think absolutely, because they're learning to use that increased drive. I think it goes hand in hand with what we work on with like principles of LSVT as well. Speak out, the whole concept of, getting that big breath and that drive, using that loud voice. Absolutely.
Yeah, absolutely. Okay, somebody did ask very quickly, someone asked about nose clips. You only use nose clips if you need them or if the patient prefers them. And then several people commented that some patients have a hard time hearing the feedback from the device. My suggestion would be to have them work with a partner or a caregiver or someone who can maybe help them with that.
Yeah, I always say in our setting, I always say save this for when I'm with you, because A, that way I can make sure they're still working hard, and then B, I can give them that encouragement and feedback. And then often that gives us time to train a caregiver if they're going to need that as well.
Absolutely. And it's such a nice device, I think, that they can carry through their rehabilitation journey. Like once the caregivers are trained, wherever they go, they can continue to use it and improve.
Yeah.
Okay, in SCI, if a patient doesn't have dysphagia but is at risk of dysphagia, do you bill for dysphagia therapy 92526 or use a different billing code?
Yeah, I think if you're using it with the dysphagia diagnosis, billing to the greatest specificity is recommended.
Okay, let's see. How does PFR translate to EMST centimeters H2O?
They don't.
They're two separate measurements. Yeah.
Yeah. I got a little bogged down and like deep in the weeds in that when I first started. And then I realized I didn't need to be quite frank. Because I would always try to figure out, gosh, could I use peak expiratory flow to estimate whether they'd be more appropriate? And I just saw this question pop up for recommending like the 75 versus the 150. And my in my setting, I have not ever had a patient that I've started on the 75 that has outgrown it and I've needed to go to a 150, like within the 2 weeks they're with
Yeah.
me, let's say. So I think it's kind of best practice, easiest, most like financially, if you just want to start with the 75 and then let someone grow to a 150, that's fine. But I've had plenty of times before you guys had the 75 where I'd try the 150 and they weren't quite ready for it.
Yeah.
So yeah.
Yeah, and I think just in general, to think about that some of these patients are not going to be training at 75% of their max, right? That might not be attainable for them once they're just starting out. So the 75 usually gives them a good range and it's you can pretty much use it. Like 75 is pretty good, like a pretty high number. So
Yeah,
you,
I've gone through the protocol when I first started learning, and let me tell you, the 75 is just fine for me.
I'll be honest, I use the 75 on max setting. Okay. How far out from STI or recent brain surgery do you initiate treatment? Um, so,
I would say patient specific.
yeah,
Often like I said, an inpatient, by the time they get to me, they're usually ready. If you work in acute care, there might be a little more finessing with doctor clearing them for that kind of thing.
yeah, absolutely. A lot of it is on a patient by patient basis. There is a question about, I just lost it. ELO,
Yeah,
paradoxical
hello.
vocal fold movement, yeah, and OSA. So I do have research lists if anybody wants to email me specifically about any of these specific areas. I'm happy to share my research with you. Do you work with those populations or have any comments?
Yeah, we have used it more. We have outpatient on site here too. So I know some of my outpatient clinicians have used it. I can't speak to OSA as much as the ILO or EILO and
Yeah,
that population, or paradoxical vocal fold motion as it was known. And I think there has been some research I remember looking it up
for
in cases
inspiratory.
and when
Yeah,
using the IMST for that. And yeah, I
yes.
think we've had some good success working on that control.
Yeah, and for sleep apnea, there's actually a lot of research, a lot more research coming out, and a lot of it is a lot of the papers used the EMST 150 specifically.
Great.
And they had some very, very good results. So those are very interesting studies as well.
Excellent.
Yes. Let's see what else we have here. Has there been any discussions on increasing the visibility of that teeny screw? And Bonnie, I want to tell you that yes, there have been many discussions. So they are going to start putting stickers, I believe, in the packages soon, but I think a really great temporary fix that we found is using a Sharpie to draw a line up from the screw so that you know
Oh, that's
exactly
a
where
cool
it
idea.
is when you're
Okay.
turning it. It's really helpful for the patients. And then we just number the pillars, one, two,
Yeah,
three, and four, like you said. And that's
I like
very
that line.
helpful for calibration. Yeah.
Great.
Are the devices owned and protocols initiated by speech, or can other disciplines initiate their use with patients in the absence of dysphagia or dysphonia?
Yeah.
Yeah,
I think so. Yeah, there was actually a paper at the recent combined section meeting for physical therapy, which is like their ASHA,
yeah,
where they were talking about the benefits of RMST for patients with spinal cord injury to work on all the things we talked about, respiratory help. And they were talking about like it could be the PT and absence of speech or the need for speech who could do that.
yeah.
Spot
So
the gains.
really interestingly, in all the rest of the world, respiratory muscle strength training is largely done by physical therapists. So I always have the reaction like, "Oh, speech can do this," and like here in the U.S. speech therapists are usually like, oh wait, PT can do this. And so it is an exercise, right? Your respiratory muscles are skeletal muscles. So you can strengthen these muscles. And then as you mentioned in your presentation, these gains translate into all of these PT and OT goals. So really you can use this intervention. You would just not be writing the goals of swallow or voice. You would be writing goals that are consistent with what you are trying to attain in your discipline.
Yeah.
And let's see. Any studies on the potential benefits of RMST and presbyphagia? Oh, We just had a really great talk, and it is available on demand from Dr. Luis Riquelme. That is on our website and as well as on our YouTube. He goes through all of that research. It's very, very helpful if that's a population that you work with.
Yeah, his talk is great.
Thank you, Ali, and yours was great too.
Yeah.
Before we sign off, I always like to point people to our website. There is a healthcare professionals side of that website that is available for free for anyone to register. And there you have access to a lot of resources, research, all these talks on demand, and all of our upcoming education. Everybody who would like to request a certificate of attendance can email me, Jenny at emst150.com. And we have a few events coming up, so please make sure you register. Ali, thank you so much for your time. We
Thank you,
appreciate
everybody.
you.
I had a great time.
Yeah, is there email where people can reach you if they have any
Yes.
questions for you?
Yeah. It is Alina, Alina
Okay.
.Holmes
Okay.
at SAI
Uh,
rehab.
S S
AI for Sheltering Arms
Yep.
Institute.
.rehab. I'm gonna put that in
Oh, wonderful.
chat.
Thank you.
Okay.
Yeah,
Thank you,
please reach
everybody.
out. I love connecting with people. And if anyone's going to ASHA, I'll be there. Let's connect.
Perfect. Thank you, everybody. Have a good evening. Thanks, Ali,
Thank you.
again.
Thanks, Jenny. All right.
Appreciate
Bye-bye.
you. Bye.